Okay, I understand that. Can you hear me now? Is it better? Can everybody hear now? Okay. So I'm going to welcome all of you again. Welcome to this afternoon's session. We understand this is a concern, and we are trying as CMAI to address the various concerns raised by not just our healthcare professionals, but also by the community at large. And today, this session, we are looking at addressing few of the concerns that are coming from our church leadership, from the communities, from those who are trying to counsel anxious members of the community as to what do we say, what is the advice we give. Do we take a flu shot? Do we stay at home? How long do we stay? There are so many questions that are arising, especially because of the fear that has already been perpetrated in the community. We hope that this session this afternoon will really address and allay some of these concerns and fears. In this context, I am very privileged and honored to introduce our speaker, Dr. Jayaprakash Muliyil, a legendary epidemiologist. Sir is also the former professor and head of the Department of Community Health in the Christian Medical College, Vellore, as well as the ex-principal of CMC Vellore. Sir, it is truly our privilege to have you on this session today. Thank you for giving us your time, and we look forward to your expertise and your ability to give us a clear, concise, and correct message. Over to you, sir. Thank you.
Thank you, Priya. Hope my voice is audible. Can I continue? Okay. I'm used to taking classes, but I'm not used to taking classes without students. So in that case, it is a new experience. I'm supposed to talk about this new virus, coronavirus, COVID-19, all kinds of names, and I think there's a lot of information already in various sources. Some are good information, some are misinformation. And I will try and address some of these issues through my presentation. I have 1 hour, but I don't have a 1 hour talk. What I thought was I'll present for a shorter time and leave the remaining for you to raise specific questions. Now, these kind of diseases always cause considerable anxiety. In 2009, when there was an outbreak of H1N1 influenza, the same anxiety was expressed. And even now, there are a lot of misconceptions about what flu did. That particular flu had one of the lowest case fatality rate. But most people don't realize it because that's the way the press covered it, information came out, whole lot of things. So misinformation is inevitable. We'll try to reduce it. Very few slides, but let me start with one. I'm not able to get that. Okay. All right. Once you know about something thoroughly, then you feel more comfortable and you are not afraid of it. This new virus has been in the limelight, in the news, and whatever we hear of it has been quite comfortable. So, at this point in time, India seems to be doing pretty well in terms of the number game. Very few, less than expected. Some people have called it an Indian paradox. And in India, what we did was, when the flu started, we went on to the first line of defense, containment. That is, prevent the virus from getting a foothold in this subcontinent. And the target was all people coming from abroad, whether Indians or foreigners, if they are bringing with them the this coronavirus. And that ICMR, with the state government support, organized a very good program, and I think it has worked pretty well. So well that there is a kind of a feeling maybe we are out of danger. And I hope that is true. If we are out of danger and we have really contained it, well and good. But I am not so comfortable with that thought. And let me explain what my fears are. So many countries are continuing to have the transmission. And we have been using a test material which has got less than 70% sensitivity. In other words, if a symptomatic comes to you and they do the test, 30% of them will be declared as normal despite of the fact they still carry the virus. The test so far used is only that good. Many people are not symptomatic but carry virus in the throat because they tend to become positive of virus 2 days before the onset of disease. And there is a group of people who are asymptomatic. We have not been able to quantify it fully, but the question remains, can they take part in disease transmission? So put these things together, the strategy that we employ in screening people coming from abroad and showing clinical manifestation may not be able to prevent the entry of the organism. So this worry is the one that provokes me, and want to talk to you about this and say, listen, it is quite possible we are doing well in containment. It is quite possible, like many people believe, Indians are resistant to coronavirus. I don't think there is any evidence to support it. There are people who say our heat will kill all the virus. Unlikely. But still, what I would like to do is pray that's true, it never comes into the country. But in the meantime, I would prepare myself for the next step, because I think chances are we'll soon be facing the brunt of this viral infection. In a meeting, Dr. Jacob T. John asked a question. If the containment fails, what then? And to understand what we should do, we should have a clear picture of what is going to happen if local transmission, that is within country transmission, starts. And it's a mental picture that we should be ready with so that we can face it with confidence. I'm going to change the slide. Can you do it? Oh. Next slide. Now, when we see a lot of numbers, and if it doesn't make sense, just ignore them. I put this up as one of my favorite slides from many years ago. You see, does it make any sense at all? Absolutely none. And many facts that we get over the in our information system is often like this. Next slide, please. So I'll try to explain to you what the epidemic is going to do. There's something that drives, there are two factors which will drive the epidemic of coronavirus. Number one is something called a basic reproduction number. I'm not going to confuse you, it's very simple. The disease transmission will depend on three factors. First one, it will depend on how catchy the disease is, how quickly it can jump from one person to another. And this catchiness, scientists try to measure using all kinds of methods. For example, measles is supposed to be extremely catchy. Take, for example, tuberculosis. In general, pulmonary tuberculosis is not that infectious as measles, but laryngeal tuberculosis is as infectious as measles. In other words, there's something called the ability to transmit that an organism's come with. Now, in the case of COVID-19, it seems to be smarter in transmitting itself than its cousin, which occurred earlier in Singapore and Middle East. It seems to get across quite well. Number two, apart from catchiness, you need somebody to catch. How many contacts do you get to affect? So if there is a crowd, naturally, the transmission will be more efficient. And the third factor is the duration for which you tend to remain infectious. Compared to H1N1 flu, this particular virus seems to remain infectious for a longer period of time. Now, once this starts setting up, the second notion you should understand is that there will be an exponential rise. Now, people cannot comprehend this notion of exponential rise, and I'm going to spend a little while on it. Apart from these three things put together, that is catchiness, number of contacts, and duration of infectivity, we create a parameter called R0. If the R0 is more than 1, then the epidemic is on. What is R0? R0 is the number of infectious cases can arise from one infectious case when everybody in the population is naive to this infection, or in other words, there is no resistance at all. In that environment, how many cases? Again, quoting the measles example, R0 for measles is supposed to be about 10, maybe more. For German measles, it's supposed to be 5. It means that each infectious case of measles will give rise to 10 more if everybody is susceptible. But R0 is something which will tell us very important aspects of the progression of the epidemic. Now, the second thing you have to worry about is generation time. How quickly generation after generation of waves, wave after wave of epidemic comes on. In the case of influenza, it was very short, so short. The person who got infected, before he knew he had been infected, he would transmit the disease to somebody. Next slide, please. Now, I want to just spend a minute on this line called exponential line. I am very poor in drawing these, but you see this graph. Ignore the second half. The first half shows an exponential curve. Don't worry about the second half. It shows gradual rise and sudden explosion. That comes up when there is a constant rate applied over time. Now, how do we come to grips with it? What we need to watch it, what is the rate at which new cases are coming, okay? And see how much of increase is there from day to day. And if you notice the new cases coming up, and it is increasing day to day, and it actually works like compound interest. You take the interest, put it into the capital, and the whole thing generates more interest. Similarly, when there is infection and then you get cases coming out, they join the infectious pool and produce more cases. And that is what creates this an exponential rate. Next slide, please. I'm going to go back to the earlier slide. Let's go back to that. No, the one with the exponential. Exponential, that's right. Now, this exponential curve tells us one thing, how fast the number of going to accrue. Let me give an example. I'm going to take that current rate of increase per day is about 15%. That is, the difference in percentage of new cases coming up is about 15%. That's where it starts off usually at a few cases each day, increasing a little bit. I'm using 15% just for a convenience of the number. Now, if you put into this compound interest formula and calculate, you will realize that in 16 days' time, the number of cases will increase tenfold. I'm talking about the new cases generated. And another 16 days, it will increase 10 more fold. So a number of cases is 100, and if the everyday rise is about 15%, it will go up to 1,000 in 16 days, and another to 10,000 in another 16 days. I mean that, and another 16 days, it will reach 100,000. It is a huge avalanche of cases. So you see, if I believe that we are under control, we have contained that infection, I don't have to worry about it. But if that is not true, and if actually there is community transmission has started, then this is what I have to expect. This is what I have to be prepared about. I have to wait. I have to be ready, or the country has to be ready to face this huge increase in cases. This is what we saw in other countries, and this is what we have to worry about. I'm not saying this is to frighten you. All I'm saying is we have to be prepared for the second stage. You see, once you stop having the community transmission started, then you have to give up the containment phase and go into the phase of slowing things down. How do we slow down? But this is the portion that we have to handle very carefully. This particular curve that is screaming up is a function of the R0 and the generation time. Now, this particular curve is not what is going to happen. What is really going to happen, it comes in the next slide. Next slide, please. Here, it goes up to a point and quickly starts coming down without any treatment, without any intervention, without any vaccination. It will spontaneously come down. Wow, why is that? The thing is, when the virus runs out of susceptible, it has to come to an automatic halt. And this is inbuilt into a mechanism. And I put an F there indicating the fraction infected. So the epidemic wave, the first wave that comes around, by the time it stops, a particular fraction would be infected. And that fraction would be a function of the R0. The higher the R0, higher the fraction. Let us go to the next slide. I have written this particular thing with a lot of anxiety. I hope it doesn't frighten you. R0 is the number of cases that can, infectious cases can come from one single infectious case. Now, in the case of this particular virus, R0 has been variously described as 2.8 to 5. And I want to tell you what happened in Velo in 2009. When H1N1 influenza came here, and there was an explosion of cases, but in a two to 3 months, the whole thing settled down. And when it settled down, Dr. J.V. Peter did a quick study. He had access to the blood test for IgG, specific for H1N1. It could tell him at the end of the first wave of the epidemic what proportion was infected. And it turned out 40% of CMC staff were infected. And this is the same for the general population also. It didn't make any difference. And that ended the whole issue of epidemic. Now, this is what a little complex to understand, but bear with me. R0 goes on, but as the fraction infected increases, 1 minus F keeps decreasing. So it comes to a stage where R0 into 1 minus F become exactly 1. And that stage is called the endemic state. You don't see any epidemic. You don't see any explosion. Everything is quiet. It's as if the disease has disappeared. It hasn't. It is smoldering, but we can hardly make out. At this time, we can actually calculate what the R0 is. Because if you look at the equation, R0 into 1 minus F is exactly equal to 1. So R0 is equal to 1 minus F. So we figured out H1N1 had an R0 of 1.7, not a big one, But this is the same number calculated even in UK. So it seemed transmission dynamic for that respiratory infection was also similar. So what would it take if 2.8 is you can calculate, if you know your R0, you can calculate what fraction would be infected by the time the epidemic spontaneously comes to an end. Next slide, please. If R0 happens to be 2.8, by the time 55% of the population is infected, epidemic will spontaneously stop. If R0 is 5, 80% will have to be infected before it comes to spontaneous halt. So this is somewhere between these two numbers is what we anticipate. So in slowing down, next slide please. This is the logic that we use. If you pretend, the graph is not very good, but the central one is the expected epidemic. We are kind of flattened the epidemic. How do you flatten the epidemic? By meddling with the R0. How do you meddle with the R0? Remember, R0 has got a component called number of contacts. That's right. You reduce the number of possible contacts an infected person can get. And that is the logic of slowing down, banning public gathering, a whole lot of stuff. Now I want to point out, there seems to be a little bit of disconnect between these two notions. In containment is working, and there is no transmission in the general population, then the slowing down doesn't work. It works when there is transmission in the general population. So as a matter of principle, it looks like that we are in a kind of state of double speak. On one hand, we say there is no community transmission. On the other hand, we say close schools, etc., etc. So does it kind of have any connection? Does it make logical sense? But I, for one, am not averse to it. But because I firmly believe the early community transmission was so slow, it's so difficult to find out. Okay? And one of the exponential curve start is all over the place. So maybe starting this shutdown a little early, increasing social distance and reduce human contact a bit early is not going to hurt, because I'm very worried that community transmission is beginning. Next. Now, given this kind of a bad news, how do I present you a more sedate picture? Well, can you see this is the pyramid? It looks awful, okay? And I'm going to tell you that this is going to be the picture of the total infection. Most people, a large number, will develop subclinical. How much I can't tell you, but many modelers feel that the subclinical infection will be a large amount. And quite a few will get mild, some serious. This is not proportionate to the real serious and real death. That will come from what the legend below. See, remember, median age for India is 26.8 years. That means 50% of our population is below 27 years. We are a young population. Okay? If the age-specific attack rate or death rate that reported from elsewhere holds good, like in Korea, we are still in the younger age group. Proportion of above 60 people is only 8%. So finally, what we have is only 92%, 92% of the population should be at a low risk. Elderly, 8% can be in trouble. Now, by slowing down the whole process, we will make sure even they get a fair treatment, and because the hospitals are not crowded. You know the Italian experience. They were just overcrowded by the whole thing. And that is not what we want to happen. When the disease, for most of them, we should remember when it comes on, if you get a subclinical infection, you come out of it, you don't even realize you had it, but you are immune for life. When you get a mild infection and you come out of it, you are immune for life. So this uncertainty, when will I catch, at least will go away. So what you have to do is face this epidemic with confidence. There's a small chance that anybody can be in trouble, elderly especially. But by and large, this particular coronavirus is not as big a killer as the one that came earlier. So there is an optimistic note in this whole picture. And I think what we should hope for is we should be able to face it with confidence and equanimity and be able to help people. Now, one thing I need to warn, the front line of defense against an epidemic will be health workers, doctors, nurses, technicians who work all over. They'll be the ones who face the onslaught of these cases. Remember, the infection is going to be all over. It's not the infection alone. They have to take care of this patient. They themselves will get infected, but they are not different from anybody outside also, once the community transmission starts. And then their morale, support, all are important in this. We have to make sure that we win people over to our side so that we face this problem together. From some of the news items I hear from Kerala, that the anxiety to reduce and contain the disease was so much, people with the disease became villains. Now that is not a good approach to any disease control. We are all in the same boat. We need to support one another. People will make mistakes, but that doesn't mean they are bad people or they are deliberately harming everybody. So I hope that we will be able to pass a message under the auspices of CCMA that here are we to help, and we will be able to support whoever in need. I will stop now. Any questions? Multiple attendees are typing. Ah, what is it? Ah. There is a period of time when you have, in the containment process, you have to worry about transmission. So we have now the lockdown has to be sensibly done. I don't think we can prevent forever corona coming unless we get a vaccine. And that is a reality. But the thing is, we need to expect the disease to come on. If a vaccine comes early enough, maybe we can. Unless, of course, that happens, somehow or other, the fraction that is required, that I showed you, will get infected. So worrying about infection once the community transmission has started is pointless. So I don't think I will keep away. Remember, most of us will develop very mild infection. Not me, I belong to the 70 plus category, so I can expect trouble. But most of you will develop very mild infection. Where is that? You got a huge number of questions. Community, what is the role of community immunity in the pandemic? We develop immunity after the infection, not before that. If you can get a vaccine quickly, that maybe you can change that. But what we are trying to say is that once you get immune, then you are no more worried about this infection at all. You are out of danger. And most of you will get the infection, come out of it, and won't even need a paracetamol to cure yourself. In general, how can mild case be immune for life? Don't understand that part, sir. In general, viral infections conform on you lasting immunity. The influenza does. If influenza 1 strain affects you and you come out of it, that strain cannot infect you again. Deepak Verghese, how are we with a reinfection? Same answer. I mean, there are people who can continue to excrete virus because of certain immunological problem. You must have heard of people who have acquired polio keep excreting polio virus for a long time without ever showing paralysis. Now those are exceptions, but otherwise, what happened? I'm fine. Keep doing that. In what stage is India actually now? I'm not an astrologer. I go by this data that the government gave. I think at the moment many people are comfortable saying we are succeeding in our containment. Remember that I told you we are using certain technology for containment which is deficient. Our system of testing is not very sensitive. So it is inevitable there will be some. Now there are people who believe Indians have special immunity. I wish it is true. I would pray for it, but I can't believe it till I have known data. What is the next one? Is there chances of a second and further waves of infection? In the case of influenza, I told you, first wave took 40% of the people, and the mortality was actually less than 1 in 10,000. I know it for certain. We counted it carefully. But again, another wave came. Why do this wave comes? Because the, the susceptible population came up. The moment your susceptible population goes larger, okay, there are more waves. Same thing will happen for corona, but there is a long time. By the time the vaccine should definitely be available. What is the next one? 30 members containing disabled, HIV and speech impairment, should we be sent to the community or quarantined within the hostel? Well, first of all, somebody has to bring in the infection, right? Who will bring the infection? And it must be into this disabled community, an infection has to be brought. And if somebody brought the infection, that must be a community member already. So it's already in the community. So keep them there. If they get infection, look after them. Remember, there are no foreign visitors coming to see them. They are there. So they are part of the population. I don't think I would do anything differently from them. How long should social distancing? Yeah. Social distancing has a very comforting thought. I keep myself safe. Does it work? Will it work? I sincerely hope. The only thing it will do is slightly prolong the whole duration of the epidemic, in the sense that people, instead of getting sick all of a sudden, will get it in installments. So in other words, it all depends on, soon we will be having a new test for IgG. It shows what proportion are infected, includes everybody. That information is necessary to answer your question. What is it? Suppose I am a contact and tested negative today. How long should I wait to do my second test if I am symptomatic? I told you, usually, if you are symptomatic, you must be positive with the new test that comes up. Have you heard the old test? I cannot guarantee you much, because I told you, I said 70%, but many others tell me it's only 50% sensitive. A new test that is arriving in the market is an excellent one. It is near 100% sensitivity. Sensitive enough to pick up 10 virus particles, plus its specificity is huge. Well, the only thing that I know is, if somebody coughs on a table and it is let to dry, in a hotter temperature, the virus will survive shorter period. So there is a slight advantage. Other than that, not a great advantage at all. This temperature thing, I have a feeling we are kind of over-exaggerating. It's nice if it will do a little bit of sterilization of the fomites, but from individual point of view, I don't think this is going to help much. Supposing I am a contact and tested negative today, how long should I wait to do my second test if I am symptomatic? Unanswered it. UK's pitch for herd immunity, sir. How rational when we are limited understanding of natural history of the state. Most viral infections have a similar pattern in terms of communicability, pathogenicity, virulence, and immunogenicity. Remember, we had some experience with the other two coronavirus also. COVID-19 is not very different. You will develop. There can be surprises which we don't know. And your question tells me, since we don't know the whole natural history, shouldn't we be cautious? Answer, yes. any difference in virulence compared to other hospitals, other countries. Now, the difference in virulence in terms of case fatality rate is primarily, look at China itself. Different parts of China had different case fatality rate. And the Korea had the lowest. So in other words, in at least according to Italian experts, they say they just couldn't handle the number they had. We don't want a avalanche of cases. This is where public and private institutions should work in hand to fight the disease. We can't, have two things can hurt things. If the disease turns out to be stigmatizing, then we are in trouble. Number two, if we don't have cooperation among ourselves, the different sections of our community, for example, government hospitals and private hospitals, they don't work together, then we are shooting ourselves on the feet. Doctors, how to differentiate early between COVID and common? Okay, one symptom I tell you, if you got sneezing and running nose, is unlikely to be COVID. Dr. Chowdhury, buy a car. He wants to know how to prevent if I am traveling in a crowded local train. I have no solution, Dr. Chowdhury. Vijayan, not to my knowledge, whether breathing exercises can help. Breathing exercises generally keeps you fitter. Your lung health is better. Specifically, nothing for COVID-19. UK strategy of herd immunity, how rational is it? See, herd immunity is not a strategy, it's a fact. When people get infected, herd immunity goes up. And that is the one that we expect for us to happen also. Nothing else. Our herd as a whole, we are immune to H1N1. Soon we'll be immune to this COVID-19 also. But the point is, they said the buildup of herd immunity will take care of the problem, but if you can do it not all of a sudden, but over a period of time, the hospitals won't be so over demanded. Role of mask in epidemic in the context of asymptomatic carriers. Deepak, I tell you, mask and prevention has a limited no. I mean, there are some studies which does show in hospital situation where you tend to use equipment which kind of creates aerosol. Using good masks do prevent infection. But in the general walking around in the crowd, masks, I'm not so sure. I don't know. I'd like to be informed about it. Thomas Nanan, is it possible to devise a self-test process which can be made available at large scale? I think this will be effective way. I fully agree with you. But luckily, the particular one that Roche has come out with, and others are coming out with various other vaccines, there will be at least 3 or 4 test kits available, and one DCGI permits it. Once DCGI permits it, anybody should be able to buy and use it. Father Thomas Nanan, thank you for that. Sir, is there any specific concern of pediatric population? I'm happy you raised it. The children are particularly safe against the COVID-19, and I'm so relieved of that. Will steam inhalation hit faster recovery? Well, it won't harm. It will be good. In fact, any bronchitis, any kind of a lung infection, it does help. I think nothing to do. I think I would use it if I got the infection. Alex Joseph, how to practice social distancing in low resource setting, water scarcity, house. I know, man. What do I say to you? We have got a huge number of problems. How do we do it? People have to live in one little room. Yeah. Joy Deepa, how long does someone remain a carrier? Well, I can't answer you fully, but I think 2 weeks is a good guess. But I heard one particular woman who was positive for a longer time. We will get this poll information. But by and large, by the time your own IgG comes out, it should start neutralizing the virus. So I think you will be all right within 2 weeks' time. All right? Priya, can I say bye?
Yeah. So thank you so much. I think there will be some more questions. Maybe we'll keep it open for another 5 minutes, and maybe I will email those questions to you. Is that okay?
Sure, sure.
And get
Or you
an
can
answer for you.
answer it yourself. You are as competent as me.
Oh, that is the best compliment I've ever received, and I think I ever will. But thank you, sir. But thank you so much for your time. Thank you for giving us clarity. And as CMAI now, with your inputs, I will slowly, I will put out a document, especially for our churches who are quite anxious to hear from us, as well as to our membership and the community at large. So thank you, truly an honor that you were here with us and you gave us so much of your expertise and profound knowledge and your clarity of thinking. Thank you so much, and thank you to the Welcome Trust for giving us a good technology support for this afternoon, as also the Distance Education Department of CMC Vellore. Thank you all for attending, and we will send you the recording of this webinar. And if you have more questions, do continue to type for the next 5 minutes, and we will get your answers compiled for you. Thank you once again, and stay
Of this
safe.
list of
Yes.
participants.
Yes, sir, I will do that. We will do that for you.
Thank you.
Yeah, thank you so much, sir. Thank you.
Bye.
Please send in your email IDs also, please. We would like your email IDs as well as your questions if you have any more left.